not here today, so instead of one extra person, we had to bring 2 people. So, my name's Bradley, and I'm the EMS Chief for the Fire Department. And today we're just going to go over basic CPR and AED use for you guys out here at Robson, and try to get you out here before lunch, before people start passing out from hunger and stuff like that. So luckily it's a lot cooler today. We have a couple more handouts we're going to give you, but the politics is going to start, so I can't hold things up any longer.
Good morning.
Good morning.
10 o'clock. All right. Well, it's not Tuesday, it's Thursday. Yeah. Usually we got worried about being talking Tuesday and everybody's ready to try to get out of here. Your attention span is very short, right? So we're here to do CPR class, and my understanding is, how many of y'all have had CPR class with my compadre Brad? Big, goofy guy, acts like a 12-year-old. That guy. Well, he's gone. So today I'll get us. So let's just talk about CPR class the way we like to present it. So we like to it's informational. It's very informal but informational. Okay. So if anybody ever has a question, feel free to raise your hand. We can help you with that. If you don't like raising your hand in front of people, we'll be here after class, or I'll be here after class, so y'all can maybe do a little one-on-one if you feel the need, okay? But one way that we do learn is by listening to our peers and our friends and stories or things like that. That kind of helps us sometimes learn and absorb it a little bit, so we like to stay real informal, okay? So if y'all have a question, feel free. No such thing as a dumb question, right? Okay. So everybody's had a class. Nothing's really changed about CPR, but some of the things that we like to harp on are some of the things that we miss a little bit about CPR classes, like when should I call, why should I call, those things, who should I call. I know they sound real simple, right? Like who should I call? If you've never done it before, call 911 sometimes is a little intimidating. You're on the phone, voice on the other end, you don't know who you are, you're already stressed out from the situation that's going on. You don't know what's going on, So talk about that. What's going to happen? You're called 911. Ask for your phone number, ask for your name. If you've never done this before, they're going to ask you for your emergency and where you are. Okay? Sometimes those things get stressful. I would be lying to you if I said people completely forget their address when calling 911. So if you're too stressed out, maybe you have somebody with you that can. I understand you guys have security on the premises. That's a good resource that you guys can use. Okay? Use your security guard. Y'all can call them if you feel more comfortable and have him come to the scene, and they can help you with everything if it's just kind of too much stress going on, okay? So you get on the phone, you call 911. 911 says, hey, we're going to send somebody to you. Luckily, you guys have station 7. You guys also have another station, engine 514, and they get here pretty quick too. So y'all have 2 fire engines and a medic at station 7 that will respond to here pretty quick, okay? So let's talk about that. How long does it seem like when somebody calls 911, we get solved out, call 911, somebody shows up like, oh my gosh, it took you guys forever, okay? It feels like that sometimes, right? And sometimes that might be the case. For example, let's just say both those engines are out of town or on other calls. It might take another station a few minutes to get out here. But for the most part, every EMS system's goal is to get to you within 6 minutes. 6-ish minutes. In a perfect world, that's what we want to do, right? So, hopefully, in that time that if you call 911, activate an EMS, the guys get on the truck, get out here, we're within 6 or 7 minutes, we get here, hopefully, around that time period, okay? What should be happening in those 6 minutes?
CPR.
That's what we're here for. Say it again?
CPR.
CPR, okay? So I like to tell everybody, this class, everything I'm mentioning is for 6 minutes of work. It's just a tool to keep in your back pocket. Hopefully you have to perform it for no longer than 6 minutes. Sometimes it does happen. Sometimes it's a little longer than 6 minutes. Unfortunately, my longest call, it took us 19 minutes to get there. We were going way out in the county. So they needed help, another ambulance. 19 minutes. That was, thankfully it wasn't something too serious, but things happen. People are busy. People call 911. We made cap 20, how many calls last year?
Right at 26,000.
26,000 medical calls last year, and it's only going up every year.
30,000.
Is that the entire Denton Fire Department or just your station?
No, that's just call for service in the city of Denton,
Okay.
which would include this area. So yes, that's 26,000, projecting 30,000 cap.
Yes, sir.
So
That's
we're
cats and trees to airplane wraps.
So we say this, so hopefully, going back to my 6-minute deal, hopefully we're here. We're doing a pretty good job at it. Luckily, engine 514 has started supplementing out here as well. So if our engine's out of town or out of the house, they come. So 6 minutes, call 911, they're on their way. 6 minutes, what can you do in 6 minutes? We start CPR, okay? So, any questions so far? Let's talk about the steps of CPR. Yes, ma'am.
Actually, I have a question on that,
Sure.
911. Can they tell where my phone is if I,
So the advanced 911 system absolutely can. They can get it within 3 feet, I believe. Something like that, Cap. They triangulate, they get it pretty close. We even have this new program now. We all, as firefighters, we all download it on our phone. It's this crazy cool app. Every part of anything has been graphed. So they can send us coordinates to this one particular box. So yes.
Yes.
That's
You
the
said
app.
you said that. My 3
That
words.
is the app one, what 3 words?
It's
Very studious. So yes. One more thing. I always bring this up with someone, bring it down. Somebody's like, oh, what do I do when I'm choking? Okay? Or by myself. We don't really teach self-rescue. But guess what happens when you call 911 to hang up and then call 911 to hang up again? They start trying to figure out what's going on. So just get that out of the way now. Yes, ma'am.
We're right on the line of Argyle,
Yes, ma'am.
Benton County. Does the Argyle station ever respond to Robson?
Yes, ma'am. So I keep referring to them as 514. That's ESD1, formerly known as Argyle Fire Department. Now they're ESD1. We have a mutual aid agreement with them. They have a station out this way. So when we get dispatched, they dispatch our station and dispatch that station. And whoever's closer is the one you get. So that way you're usually covered in most circumstances all the time. All right, so if our station, if Denton Station 7 is busy on a wreck or something, then Argyle, they get the call at the same time, and then they talk to each other who's closer, and that's who goes. So it's, you guys got pretty good coverage. Another question?
Right here, Dave.
I'm sorry.
Can you tell the ambulance that comes with equipment which hospital you really need to go to? Because say it's a specific condition and you know that you've been told by your doctor, if anything ever happens, go to this hospital versus that one because this is geared more to your patient. So you allowed to tell the ambulance what people which hospital to take?
So that is a sticky conversation, right? Being out here is a little bit different because you can either go to Denton or y'all can, like there's Alliance Hospital down the road, right? So here's the thing. If, let's just say I work in Station 5 district, that's over by Bonnie Brook, okay? Let's say we're at North Lakes Park over there and somebody has an emergency. They're like, hey, they're really sick, really sick. And they want to go to Regional or Medical City, or they want to go to Alliance Hospital. Well, you're really sick. I don't think it's a great idea for us to pass a hospital for you to go to another hospital. Now, you have a certain something going on, right? You have a certain condition that is imperative that you go to that hospital. We will sometimes make exceptions and yes, follow your instructions and your wishes and do that. As long as like, us getting there is going to cause something worse to happen.
Okay.
We don't like passing hospitals in a very bad emergency situation. So, like, there's a machine called an LVAD. I don't know if you'll. It's a machine that pumps blood for your heart. They carry it in a bag. It's a weird thing. We go on that person. He's just kind of sick, not feeling well. There's only a few doctors that can handle that. We will go to that guy's hospital and get him there or her there. Make sense?
Yeah.
It's all kind of situational. So, good question.
Is there a level 1 trauma center in Denton or in this region? Right.
Level 1, no, there's level 2. Medical City's level 2. Now, the difference between level 1 and level 2 is level 1 is a teaching hospital. So level 2 has the same capabilities as a level 1, except the level 1 hospital is just geared towards the doctors, future doctors, and future nurses and of that nature. So level 1 and level 2 are the same thing. We have a level 2 is what Medical City is. Yes. Good questions. Good questions.
So Presbyterian is not considered a,
So every hospital specializes, right? Medical City, or Presbyterian, I believe, is trying to get their trauma certs. That's years from now. They're working on it. But what Medical City, what Presbyterian does have is stroke accreditation.
Okay.
Okay, so we can take patients that are having strokes, we use that hospital for that. Now, Medical City's going after that certification too, or they haven't yet? The stroke accreditation?
Yeah, they have stroke.
Comprehensive, so.
They have comprehensive stroke.
So we can take them both hospitals, but that's, for a while, Presbyterian was a hospital for strokes.
Also Presby, for those who, pregnant women and babies freak them out, they have the labor and delivery there.
Yes. So Medical City does not have that. So again, going back to your question, when you say I need to go here for that, we're as the medic showing up, have to determine what's going on and what we got, where is the appropriate within your wishes, hopefully.
The only difference between the stroke centers between Presby and Medical City Denton is if you have to have surgical intervention, Medical City Denton can do it on site. They don't have 24/7 coverage yet because during COVID they lost a couple of their nurses coverage 24/7, so they're almost back to 24/7. If you have to have surgical intervention on stroke and you go to Presby, they can handle you, get you ready to go and stuff like that, but then they'll ship you to Fort Worth. So that's the only difference.
Another thing I think that probably be a little bit, a little bit more clarity is that if you had a situation where it was a traumatic event to a person of your family or yourself, there's been some questions just in the past of, hey, my doctor's at Presby or my doctor's at Presby. Well, us in the Denton Fire Department, we're going to transport you or your family to the best outcome and the quickest response that you're going to need from a hospital. So that trauma center is going to be Medical City then. So there's been kind of some, well, you know, we always go to Presby, we always go to Presby. But when you get transferred over to the north side of town, they don't have the things or the doctors there to handle the situation. So you're going to get transferred out of here. So that's why it's in the best interest where you need to go to MCD so you get the needed care. Is that clear enough? Because there's been, you know, it just gets to some questions. We all go to Presby and someone hit their head with that. It's a bad head trauma. They need to go to Medical City Denton because that's where the trauma center is.
If it's a minor injury and stuff like that, we'll still go to Presby. We take about 40% of our injuries to Presby still, so it's not like it's out of the realm completely. But if it's more severe, my biggest deal with all our paramedics is we want to get you to definitive care as quickly as possible. We don't want to take you to a hospital and then you get shipped to another hospital, stuff like that, because that delays your definitive care and defeats the purpose of going on it.
And the last thing that is people always worry about a doctor's here, about doctor there. The ER doctor, there's something going on specifically with you, they need to talk to your doctor, they will call your doctor from the ER and have a chit chat with you. Get that vital information that they might need. So that does happen too. Doctors do talk to each other. Good questions. All right. Any more questions? I like having questions. I like debunking things if at all possible, or just getting some good information out of them. And if y'all have, you got the guy that's in charge of all the paramedics, and then you have the guy that used to be a paramedic and is now the captain of the paramedics. So you kind of got, and then you got me.
Delonte is probably our busiest, one of our busiest stations. He's at the busiest station. EMS wise, so probably the second.
Second. Our last report was third, I think. Third. Like by 20 calls. So, all right. So we're back. We called 911. Now we have 6 to 8, we'll call it 6 to 8 minutes to wait, and something's going on. We think this person needs some help. We think there's something we can do. We want to intervene. What are some of the things we can do? All right. So we've already called 911. I'm gonna call Fred here. So obviously, we've kind of changed some things with CPR, American Heart Association, because, some of the things we were doing back a few years ago were real silly, right? You get a guy that looks like this, his color does not look great at all, and most of us can tell this is not a good thing, correct? So one of the first things they used to do, it's been a few years now, but they used to say, well, hey, you get on the phone with 911, they say, hey, go ahead and listen to, see if he's breathing for 15 seconds. I don't hear you. Hear your me, you have bad hearing anyway. It doesn't work, right? So they were like, you know what, that's silly. Why are we listening to this guy for 15 seconds? Look him over. Does he look sick? Does he look dead? All right, let's just get this out of the way. He's dead. All right, he's dead. Dead, guys. Class A would be dead. No. So when we expire, we can't make it worse. Okay, there's no such thing as dead times 2. We're not going to make it worse. So we're trying to make a good situation better. So just kind of remember that. Anything you do from this point on, you're not going to make it worse, because if we're doing CPR on that person, they've already expired, correct? So, like I said, there's no dead times 2. All right? And before I dive into this, there's one thing called the Good Samaritan Law. Good Samaritan Law says that you're covered in all states as long as you're doing something prudent. You can't be held liable for it. Okay? Something prudent. That means, like, you were trying to help him. Maybe you start doing CPR. It happens all the time at 2:30 at the bars. You're doing CPR, you're doing this, and they say, get off me. Well, he was just a little tipsy, right? And that happens all the time, right? So he can't go and sue you now because he's having a little chest pain. You legitimately thought he was dead or something was wrong. Can't be helped. Now, you pull out your pocket knife, put it over the chest, and do open heart massages. D didn't tell you that, okay? You might have to go to court for that one. But as long as you're doing something prudent, trying to make a bad situation better, you can't be held liable for it, okay? So with that, we try to, the hope of that is that more people are willing to do CPR, okay? So now at that point, you want to do something, this person is sick, ill, whatnot, he's not responding appropriately. If you're me and I show up on scene, one of the first things I do is a storm rope, okay? Take this, go home and practice on your loved one or a friend and see how well that goes. But you put your knuckles right here in the sternum right there, real bony area, the knuckles real abrasive, it should cause some kind of response. If you don't get that response, you're calling 911. The next thing you can do is, we teach checking for a pulse, okay? That's difficult sometimes, checking for a pulse, especially if you haven't been doing and practicing a lot. So one thing that is acceptable is just looking this person over. Just give them a quick 10-second look over. If they look like this color, they're not breathing, they're not moving, they didn't react to that, we're gonna go ahead and assume that they probably need CPR, okay? Again, we're gonna just assume that they don't look good. We're all humans, we know what a person that is alive should look like, okay? So, we always talk about baring the chest. That's a question that comes up. We should bare the chest. And by that I mean take off their clothes, or take off their shirt. Leave yours on, take theirs off, okay? Teach at college campuses, and that's like I had a kid one time say, take off your shirt? I'm like, no, don't take off your shirt. So I had to say that. Leave yours on, take theirs off. And the reason we do that for several different reasons. One, I can see where I need to put my hands, okay? 2, I can really see if that chest is rising or not, okay? We wear blousy shirts and thick shirts. It's about to be wintertime, hopefully, and sweatshirts and jackets. We got to get that stuff off. Okay? So, bare the chest, we're looking him over. I determined by either looking him over or checking for a pulse that he needs CPR. I bared the chest, he's wide open. I can see where I need to put my hands. Where we put our hands. Center of the chest, mid-nipple line. Okay? In your book, it may say the lower third part of the sternum, but if you remember middle of the chest, or mid-nipple line, middle center of the chest, you should be good. Okay? Make sense, everybody? So I'm going to put my hand right here, right there, and then I'm going to cross my hands. Now, I'm going to go nice and hard on this table, right? So how deep do I go? 2 to 2.4 centimeters, or 2.4 inches. I don't know where they got the 0.4 from. Pull out your ruler, hopefully. If you got a ruler, bring it with you to do CPR, I don't know, but 2.4 inches, okay? So 2 to 2.4. You go down, and then when you come up, we let the chest recoil best we can, and we go back down, okay? So think about this. Every time we do this, what are we doing? What are we trying to do anyway? We're trying to squeeze the heart. When we let up, the blood, hopefully, is refilling the heart, okay? So that we can hopefully squeeze them out. Now, the thing is that we're only doing 30-something%, I'm not doing numbers, 30-something% of what the heart would do on its own. So we are not a super good pump, okay? But we're doing something. We're trying to circulate that blood. So how fast do I go? How many? It's almost about 1 per second, okay? But what we like to say is go to the beat of Staying Alive. Anybody like music? Beat of Staying Alive is a good one. Another one, Bites the Dust, not so good, but it's don't do that. Don't sing it out loud anyway. It's a good song. We like doing that one. Single, all the single ladies. Beyonce does that one. Justin Timberlake does Rock Your Body.
What?
Oh, yeah. Listen here, sister. There's a whole CPR playlist. You just go on your streaming music app and you just find some good CPR music. Okay, so the point of it is that we play the music and we can kind of stay on beat. Okay? Find you a good song that you can stay on beat with, and you can do that. Luckily, we have these fancy mannequins. Hopefully the batteries work. What you will see that if you're doing it at the right speed, you should get 2 lights. If you're going a little slow but you're doing okay, you'll get 1. If you're not doing too good, it'll show red. All right? And it lets you know. Now, a couple factors in that. You have to get a good squeeze, and you have to be going fast enough. A couple more things that makes this easy. One is you'll see that my arms are locked out and I'm bending at the waist. Okay? That's gonna help you be the most efficient as you possibly can be. Number 2 is my friend Fred here decided when he expired he was going to clear the table and lay on a hard surface. Okay? Thank you, Fred. All right? Now, in reality, I like to keep it real sometimes. That's not where we find Fred sometimes. We find Fred on the bed. You know, we start to feel sick. Where do we go? We go to the bed. Things like that. Another place we like to go is to the bathroom. You know, and we go to the bathroom, we expire, and now Fred's wedged between the toilet and the bathtub. You know? So those kind of things happen. So the point is, 1, get him to a hard surface, okay? So that you can do efficient compressions. 2, get him to an open area, somewhere where you can work, if you can, you know? Some of us can do that. I'm not a little guy. I'd probably be to take a couple people to get me moved. You know what I'm saying? So you do what you can. And that's what CPR, that's what this class is about, guys. Is doing what you can within your time limit before help arrives, okay? A good thing is this class is about guidelines, and there's no CPR police. They're going to drop out of the ceiling and tell you did it wrong. Okay? We're doing guidelines, and we hope that you come to these classes, make some muscle memory that you can, that you're, give you some confidence, so that when the time comes, you can do this. Make sense? All right. So we're back to CPR. We're going about 100 to 120 beats a minute to the beat of Staying Alive. We're going 2 to 2.5 inches deep on our compressions. And we're just staying pretty consistent. Now, I didn't say at any point that you have to count. Matter of fact, the caller dispatch that day, you just do 600 compressions. That's 100 compressions, you know, you just do 600 compressions, that's 6 minutes worth. Hopefully somebody's there by then.
So you don't stop, you just keep going.
So when we're doing this type of CPR, and I like to call it CPR with options, right? And the options are 1, we just do compression only CPR, which is what I'm doing. I'm not gonna stop. Take that back, or rephrase it. I will stop every 2 minutes, I'm sorry, to reassess my patient. So I'll go for 2 minutes. We'll say we're at 2 minutes. I'll stop, look my patient over. If you're comfortable with checking for a pulse, check for a pulse on the side closest to you. If you're not really comfortable with checking a pulse because you don't think you can feel it, then just look him over. Does he still look the same as he did before you started? Yep. Then I'm gonna go back to my compressions. 2 more minutes. I have not once put my mouth on this poor soul, have I? And that is an option. Why? What are some things I wouldn't want to put my mouth on Fred for?
Why should you do it?
Why wouldn't I want to do that?
Well, you don't know what kind of diseases he could be carrying.
Thank you. We don't know. Yes, sir.
What about the airway?
What about getting some air into him?
If he swallowed his tongue, or his tongue is...
Oh, so we'll talk about choking a little bit, but I will address that swallowing your tongue part right now. Has anybody ever done that yet? I promise you, I've been hard enough sleeper that I should have done it at least 100 times by now. Okay? Your tongue does relax, but it will just kind of be in the way. Good thing is the good Lord gave us nostrils, so hopefully we breathe through our nose as well. But your tongue, yes, if you bite your tongue off, I guess it might fall back there and cause an obstruction. But for the most part, your tongue just kind of relaxes, and you should be okay. But specifically talking about giving air to this person, we'll get there in a second. I'll address that. Okay? We'll come back to it. So So we're doing our compressions, we're doing here, we're gonna check this person every how many minutes? 2 minutes. We're gonna reassess our patient. If they look the same, we go back to our compressions. Okay? Sound good? So what I'm saying about going back to putting their mouth on them. Why would you want to put your mouth on? Well, we have COVID. We have flu season. We have, if I'm on a college campus again, we have herpes. We have, name it, Hep C. Just Hep A, B, C, D, E, F, G, right? We just have so many things.
Egg salad.
Egg salad. We have the multitude of things, okay? So there are some times that you might not want to put your nice, healthy lips on somebody else's, right? If y'all walk around Denton any amount of time, you'll probably see them, okay? So that's why we do CPR with options. If I'm walking around town, I'm not on duty, I see somebody needs help, I'm comfortable doing this. If this is a family member, somebody I care for, Fred owes me money, something like that, I might be willing to, to give them some life-saving breaths, okay? Let's talk about the science behind that. Why is this okay and how are they both okay? You think we need air, right? So here's the thing, most of us are pretty healthy individuals. We're somewhere between 98 to 92% oxygen saturation in our blood cells. When we expire, when D-bell falls down right here, it doesn't all just magically float out of it. It stays in there. And it stays in there, depending on your health, for an X amount of time. So if somebody shows up and starts doing this, we're still circulating blood, we're still circulating a little bit of oxygen, we're still doing this. Now, at some point, this is not enough. But for the 6 minutes that we hope we're doing it for, it should be plenty, okay? Now, this is somebody we care about, your breath. If you guys didn't know this, just a little science. There's roughly 21% oxygen in the air, okay? I inhale it, I exhale about 14% oxygen, okay? So when I exhale, breathe into his mouth, he's getting about 14% oxygen. What that means is, when he exhales, there's 7% oxygen left. If you want to take a breath, go for it. No, I'm just kidding. But that's the math behind it. Some people, they always want to know, well, how come you can take a breath and give it to him? Because technically there's still a little bit of oxygen in there, and that's why we take a breath and we give him a breath. But we'll get to that part of it.
There's a ton of nerd level science involved and stuff like that on it. And more studies are coming out. The number one thing that people can do for a person to survive is chest compressions. Most likely, bagging someone next 5 or 6 years will probably come out of standard, regular protocols. We'll just put them on high flow oxygen. Oxygen will help, but at 100%, as Dee said, when you're just blowing out your mouth at 7%, 14%, it's not as effective as if you're doing chest compressions. Every second you're off of a person's chest and up doing compressions, there's a bell curve, and it dramatically drops, and the chance of their heart restarting dramatically drops every time you stop compressions. So there's a lot more science coming out saying, just stay on compressions, stay on compressions, stay on compressions.
I will say this, that before we start teaching hands-on CPR rate saves, and when I say save, I mean like somebody walking out of the hospital. It's only like 7% nationally. We weren't doing super good. Then we started saying, hey, you know what? You can do CPR only, or hands-only CPR, excuse me. And then the rates drastically, immediately improved. Why? Because people are willing to do this. Fun fact. Paramedics show up, they start doing CPR on someone. They get them back. More often than not, it's not because we showed up and did all this and pushed medicine and did this and did this. It's because somebody was on scene prior to EMS showing up doing this. Okay? Your survivability rate goes exponentially higher if someone's on scene doing compression before EMS. Our medications work on blood pressure. If you don't have very good blood pressure, then most of them won't work. But doing these compressions, getting that blood pressure built up, we show up, pop a couple of our drugs, boom, 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 like, oh, look, got a pulse back, let's go. It looks like we did it, but for the most part, it was the bystanders that were there first. And that is why we love to teach CPR, because that helps our patients that helps us, that helps our community. It just, everybody working together is what helps save that person. Make sense? Okay? What if I can't? My wrist hurts, my arm hurts, I can't do it, I got one arm, I have no finger, whatever. Okay? Somebody shows up, hey, I want to help, I don't have a CPR card, I've never done this before. Well, maybe you've taken this class enough that you can instruct that person on how to do it. Hey, put your hands right there. Yep, Now go as deep as you can. Go a little faster, okay? Keep doing that for 2 minutes. Maybe you're that person. Yes, sir.
Is there any, can you do too much and actually break something?
Good question. So like I said, I like to keep it real, okay? So we're gonna keep it really real. All right. So you have the sternum here, and you have cartilage, and then you have a rib cage. So when you start doing compressions, more often than not, you start to feel that pop, 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 okay? Not always is that ribs breaking, but what it is that cartilage separating. And the way I like to think of it is, pop your knuckles or your joints, and once you pop them one time, can you go back and do it again? Not immediately, right? So more often than not, that's kind of what you're feeling. Now yes, can you actually break ribs? It does happen. As the older we get, sometimes the more fragile we get, kids or whatnot, osteoporosis, like, things can happen. Okay, so that is a concern, but it doesn't keep us from doing what we need to do to help this person. Because if we can get them to breathe and the heart to function again, ribs heal. Correct? Jason wouldn't play the whole football game with broken ribs. Fine. But good question. So that is something that does happen. Okay? And since we're on the topic, sometimes when people expire, we keep poo-poo on ourselves. Our muscles relax, and sometimes there's a little bit of vomitus and spit up. It's not pretty sometimes. Sometimes people defecate or they pee or urinate themselves. Things like that happen sometimes. So don't be surprised if you ever come across it. You have that. Sometimes that's life, and that just happens. Okay? But please don't, if you can at all, don't let it take away your focus of what you're trying to attempt to do. And just understand that that's. And then you get them back and they're embarrassed. It's like, don't be embarrassed. It's normal. So, all right? Makes sense? All right. Real quick. So if Fred falls down, I'm going to shout for help. Hey, somebody call 911. I didn't mention this, but we're here at the clubhouse. Y'all have these in the clubhouse, not the specific one. Y'all have Life Pack brand, if I remember. It's been a while. Go get the AED. Somebody runs to get the AED. They're going to go get that. And while you're doing that, you look at the person. You call 911. Now you look at this person. You determine they need CPR. You check for a pulse, or you just look at them. You said, yep, need CPR. You start with compressions. I don't know who this person is. He's probably a very lovely person, but I don't know who he is. So I'm just going to do compressions. I'm going to go for 2 minutes. I'm going to look my person over. They still look like they're dead. I'm going to continue. 2 more minutes. I'm going to look them over. Oh, color looks better. I think he's breathing. Yep, he's breathing. Now what? No. First, we need to roll to their side. Okay? Well, D, what side are we rolling to? Okay. We can roll. American Heart Association says we should roll to the left side. Any of you women that have had babies or been pregnant before, do y'all remember, y'all can recall, like, you didn't lay on your right side, right? When you were pregnant, there was a reason for that. We got a bunch of anatomy that runs down this side of our body. Think about this. This person did not have any blood flow. Okay? It wasn't working very, it was slow. You got it back. It might not be working good, but it's good enough that, hey, he's doing better. And then you lay him on his right side, and all those organs shift to these big veins. And now they're slowing down the blood flow again. We don't want that. So we say we're going to roll to his left side. Okay? And that's why we do that. Simplistic reason of why we do that. Roll him to the left side. Keep everything away from this side. All right? Now just make sure if I'm over here and I rolled him, I'm going to make sure that I'm watching him so that I can make sure that he's still breathing and nothing bad happens, because sometimes the truth of the matter is you give it back and they can go back into cardiac arrest. Okay? Yes, ma'am.
When you're rolling the upper half usually.
You're going to roll as much as you can. Yes, ma'am. And the reason we do that is because, like we talked about the vomit or things like that might be in the mouth, it just helps let that stuff come out. Okay? Just just to help, let them breathe. The lung will open up and expand. Also, the baldness will kind of come out. Okay? Make sense? And we just watch them. If something bad happens,
If they're large and you cannot hold them over?
then you did the best you could.
Oh.
That's the truth of the matter is you did the best you could. We can't always, sometimes people ask, why do y'all come on the fire truck? Why do my fire truck specifically, there's 4 guys on the fire, or the plant that comes, and there's 2 guys on the ambulance. And they're like, why did you bring that many people? Because we've been on calls where we've had to lift the 600-pound guy up, and we've been on calls where we had to lift the 2-pound baby. Most times we don't really know, they give us a cone, we just go. And then we find out later, and you know, it is what it is. More paramedics, more eyes, more hands, more brains, more knowledge, more muscles. So, but for you, in this instance, just do what you can. If you can't roll them over, you can't roll them over.
Can you turn your head?
Yeah,
Yeah, like
absolutely,
that.
absolutely. Yes, sir.
What if you walk in on somebody and they're down and they're cold? Dude.
So there's a little bit of do what you think is appropriate in there, okay? And even for us, there are certain situations where we absolutely just kind of go, you know what, it's probably past this time that we can actually work somebody. So you, as being a bystander, will have to make that decision kind of for yourself. For us, like you said, you walk in and they're absolutely cold, then they're probably been expired for too long. There's other things, signs of life that we look for. Several different things that we look for that we as paramedics will look at and go, I think they're too far gone, okay? Being cold is sometimes one of them, but it's not the only determining factor for us. But you as a layperson, you walked in and you see someone on the ground and you feel that they are too far gone, then that's fine. You're not super medically trained. I mean, you had a CPR class, but if the paramedics sit there and decide for whatever reason they're going to work that person, then, you know, you didn't know that.
Yeah, if they're cold from just being on the floor or whatever, that's one thing. Like, but if, I don't think you guys have ice baths here, but if like someone pulled them out of a pond or something else and it's a cold pond or whatever, we're going to start CPR because it's crazy how the body can react to cold immersions. There's been cases that they've been underwater 30 plus minutes and then they're brought out and CPR's been initiated and eventually they get them back. I mean, it's usually a long process, but.
So that's a little bit, so that is different because that's environmentally cold, right? The environment made them cold compared to, it's pretty warm outside. If you go to someone's house and it's warm outside, you know, the thermostat says 78 and their body is cold because the blood was not flowing in it anymore. They probably expired. Or been expired for too long. So it's kind of a judgment call. Yes, ma'am.
Is there a case where someone be passed out and have a bleeding situation? What would be?
A bleeding situation? So they're outward bleeding? Is that what you're speaking of? Yeah, when you're kind of going kind of into the first aid kind of thing. You know, one thing we like to do is, you know, stop the bleeding, okay? So first, yeah, but we want to make sure they're breathing first. Because if they're not bleeding, then we don't ignore the blood. I know the problem with the blood is it's like moth to the flame. You see the blood, you want to go straight to it and solve that. But first, let's see if they're breathing first, okay? If they're breathing, they have a pulse, then that's good. Now we can solve the bleeding issue, depending on whatever it could have been. All right, but first we always go back to the breathing and the heartbeat first, okay? And we do more about CPR than we worry about the blood.
It seems maybe not quite that good, because if they're depending on kind of where the blood's coming from, you start doing compressions, more blood may be coming out.
True, absolutely.
So accelerate the blood loss, and that can be counterproductive.
So here's the thing. So now we're going to get into the realms of traumatic CPRs. Okay, and anything, the word trauma, when you introduce that word, now you're introducing the fact that this person needs probably more than me doing this, me giving medicines. Now you're introducing the fact that now this person needs surgery. They need something to fix that bleeding. So here's the deal. It doesn't mean that we don't perform CPR. We still perform CPR. We as paramedics, we have a couple of tools that help stop or slow down bleeding. Tourniquets, forceps we can grab, quick clot, things that we can use to slow down bleeding. but nothing that we can do to absolutely definitively stop it, except for driving really fast, keeping their heart and lungs going, and getting them to a surgery center so a doctor can get them to an OR and fix the bleeding. Again, so with traumatic bleeding, we can still worry about the breathing and the heart pumping. That's always number one. But you're right.
For someone being able to walk out of the hospital from a traumatic CPR, it's like 0.9%. I mean, it's a pretty bad situation. We've actually had a couple.
We've done it.
In the city of Denton in the past couple of years.
Yeah.
Which is miraculous, but nationally it's like 0.9%. Regular CPR, I think we average about 20-24%. So we're we're on the high end of the national average there. So
when we say 22%, you're like, that's 22% in school, you're failing grade, right? 22% in CPR is thousands of lives. So just think of it like that. Yes, sir.
How many calls do you get people fall and crack their head?
a lot.
Yeah. He probably knows better than I do. To me, it seems like every day. I don't know if it's every shift I work, but it seems like that. It happens.
So we just, going back on the history, we just surpassed 10,000 transports this year. First time ever for the Denton Fire Department. It was like 2 weeks ago. I would say 15 to 20% of falls. So we don't really differentiate between falls and falls that people struck their head to. I mean, striking your head, especially if once you hit my age, 50 and above, it dramatically changes things. And the older you get, especially if you have a head, it's called a head strike. No matter if it's just a fall or an MBA or whatever, chances of you being more severely injured go up exponentially. So it'd be nice if everyone walked around with little helmets on.
Right. Everybody walk around their bubble and be safe. Not probably gonna happen for a while. All right. So good questions. I want to give everybody opportunity to practice. So let's get to that. We'll field some more questions for sure, but let's get to a couple of practices. Some of you groups, y'all only have 2 people. Y'all have 1 mannequin at each table. I'll go and practice this and kind of go over that. And then some of you bigger tables, I put 2 mannequins at them so maybe 2 people can swap. So I just want you to get your hands on a mannequin, just kind of get the feel for it. Absolutely. I don't know, that's there you go. That's it. That's it. That's perfect. That's it. Okay. So let's see here. There you go. Now, right about there. Center pitch chest. Now, give that a try. There you go. That's it. 2 green lights. 2 green lights. Just gotta remember, keep going deep. Here we go. It is tiring. It will make you tired. That is for sure. Right. So for you, you don't want to be CPR. Exactly. All of your all weight. floor very often. So, everybody's That's why I get going on. You're still doing a good job. You're still certainly someone who's just not your job. I agree. After a couple rounds. So what? That's ADs are short. Only a handful of people who would know how good we're doing.
Push this button and it'll stop. And so you'll come back, or otherwise I can drop it off. I have to go to Cross Ridge anyway. Yeah, I can drop it off at your house. Okay? Okay, I know. Thank you.
We actually have 85 in the city right now. We're not going to win that. The key is if you lock your elbows, basically you're over course.
Everybody got a chance to practice.
So we have firefighters that just try to use their arms.
That's just what you do the best. Keep going, do you stop? Okay, first of all, if they ever, at any point you're given CPR, they tell you to stop, feel free that you can stop, okay? But if you start to get a few signs of life, you're doing this and you're like, he's moving, yep, he's breathing, then go ahead and you can stop, okay? Feel confident in that. Now, we as paramedics, there are sometimes, and I don't want to get into it too much, there are actually times where somebody might have a very, very faint pulse, and we still do compressions. And that's because that very faint pulse is not enough to sustain life. So there are instances where we as paramedics might still do compressions on somebody that has a heart. It is different. There are times that we might be breathing for them with our bag, and they are still breathing on their own, but we're helping them. So yes, for you, I would say if they ever tell you to stop, get off my chest, you stop. Or if you see signs of life like adequate breathing, and we know what adequate breathing looks like. Adequate breathing is get breath in, get breath out. When we start seeing that motion, you're probably okay, but we need to monitor this person, okay, until help shows up. Now, the difference between a good respiration and a bad one, this here, that is not adequate breathing. That's what they call agonal respirations. And most times that's just a reflex in the body. It's just a muscle reflex. That is not adequate breathing. If you see that, you're probably going to be doing CPR pretty soon if you haven't started already. Okay? Another question was, I usually hit this in the class, is your size versus their size. Okay? So we teach this class and we've been talking about doing compression with 2 hands, right? What if this was a 6-year-old child. I don't need to put 290 pounds on this child. I can do it with one hand. I can use the table to support my weight, and I can do one hand. It's your size versus their size in any circumstance. Going back to the 600-pound guy we run on. Well, we might have to jump off the ceiling and land on his chest to get one pump, you know, like your size versus theirs. So yes, absolutely, if you have one kiddo that's very small, if I can get this motion here with one hand, then great. If I can't, in 2 hands, your size versus their size. 2 good questions. Yes, ma'am.
A baby, can you use your fingers?
So baby, 2 fingers, you can hold. Now with the baby, we can put the baby on a hard surface like a table. You can even hold a baby, we teach that. You can use 2 fingers, doesn't matter which fingers. Use 2 fingers,
Same place?
center of the chest, mid nipple line, 2 fingers on baby. Absolutely, okay? So that's great. Yes, ma'am. Oh, go ahead.
If somebody's on a bed and somebody's beds are really high, you're not getting the leverage that
Right.
you need.
Assist them to the ground the best you can. And I'm going to use you for an example, okay? What's your name, ma'am? Miss Elaine here was having a little bit of difficulty doing her compressions, okay? She was doing good. She was going the right speed, and all it took was about 5 inches of difference putting the mannequin from the table to the chair there. That 5 inches of difference got her 2 green lights, and she was doing it perfect. So that is sometimes the difference. So yes, if they're on a hard, soft bed, if you can, we do our best to get this person down to the ground if you can, okay? Again, you're just doing the best you can. Does that make sense? A hard surface like the floor is best. We, in some of our CPR classes we go to, we don't always ask people to get on the floor because sometimes we fresh knee surgeries and things of that nature. If you can get on the ground, it's better, but in class, we understand that you want to be on the table. Whatever works, as long as you're getting what you're wanting out of class. Okay? So, good job. Anybody else? Did you have a question, sir? Anybody? Okay, moving on. We have AEDs in a spread around, and you're remiss if I don't want to lie to you guys. Last time I was here, there were at least 2 here, and I thought the security guard had one on his cart. Not 100%. Does that sound about right? Maybe?
There's about 9 here.
There's about 9 or 10. Yeah, it's been a while since I've been with you guys. Are they still Life Pack brand? Does anybody know?
Yeah,
The yellow and black ones?
They're switching out to the white ones.
Okay, gotcha. So that's awesome. They
Right
work,
outside the television one.
so they work with our equipment, so great. But the good thing about AEDs is they're all simple. They all work about the same. They just look different, but for the most part, they are all very easy to use. They usually come with the shocky thingy. Okay, AED, automated external defibrillator. It comes with a set of pads, and they're usually instructions. Now, some machines are different. Can't promise you this, but like sometimes when you open the package, it starts talking to you. This machine, we have to turn it on.
If you find a yellow one around Robson Ranch, you manually have to turn it on. The white one's like right outside this door. The second you open the lid, it turns on.
So but they all work the same. So with this one, that's when we plug it in. We have pads. The pads will have pictures. You know those are for the guys, right? Because we don't read instructions very well, but we look at pictures. All right, so there's pictures. So we just put the pad where the picture shows to put it. Boom, 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 rather, and then we plug it up.
Analyzing heart rhythm. Do not touch the patient.
So I'm not touching.
Shock advised.
Remember we talked about bearing the chest?
Stay clear of patient.
Stay clear.
Deliver shock now. Press the orange button
An
now.
on button. I have a bright, flashy orange button. It's not annoying. I'm going to make sure nobody's touching my patient.
Shock delivered. Pause. Begin CPR.
How long do we think it'll go quiet for? 2 minutes. It'll go quiet. So we got 2 minutes. 2 minutes to talk. Somebody asked me while we were doing the CPR, what about bras? Go ahead and cut it off. He won't care. He'll be fine. That's a because there are a lot of guys that wear them. It's real weird out there. So, yeah. They don't have the, no. They're a little bit older than 12-year-olds. More mature. So, yes, if we have a bra, we do tend to remove those because some of them have more metal than others, right? We just use electricity or the potential for us to use electricity. Somebody goes out here, we know the AED is coming, let's just get everything off, okay? So now the shirt comes off, the bra comes off. I mean, we all understand that we all want some privacy, okay? This is not our best shining moment, but it's just the truth of the matter is some bras have more metal than others. We'll just get them out of the way now. And then we can put the pads on without worrying about that. Cover them up, protect them, crowd on them, whatever. But yes, sir.
I want to pick up on something you just said. When this stops, and you said go back to CPR, do we leave the pads on?
We leave the pads on.
Everything stays in place.
Everything's there.
So just do CPR.
So right now, while I'm talking, I would be doing this.
Okay. And then at what point is another 2 minutes goes by and you try it again?
So the machine. So once the machine is here, the machine's the boss. So it will start talking. Now some machines. I haven't seen y'all specific machine, but there's Zoll makes a machine, and it talks to you the whole 2 minutes. It gets annoying. It tells you, go faster, deeper, you're doing good, this, that, and the other. And you're just like, okay, when are you gonna stop? You know, but it talks to you the whole 2 minutes to let you know. Some screens have a timer, big numbers, so you know, okay, I got about 30 more seconds, cool. You know, every machine's a little different. Ours is this one is a little bit more basic. We just get a little red light that shows you that it's still on.
Stop CPR.
So 2 minutes is up, I'll stop my CPR.
Analyzing heart rhythm.
And this is the boss.
Stay clear of patient.
We don't want to touch because we touch, it could throw off the rhythm.
Analyzing heart rhythm. No shock advised. Paused. If needed, begin CPR.
So how do we know it's needed?
Are they breathing?
Are they breathing?
Nope.
Nope, he's still the same color. I'm just going to do this. So there is a rhythm happening behind the scenes that is not a shockable rhythm. And since it's not a shockable rhythm, the only thing you can do for this person now is... Now, the other situation could be, it said no shock advised. I looked the person over. Oh, they are in fact breathing. He in fact does have a pulse. That's why I didn't want to get shocked. Now I'm going to lay him on his left side. Okay? Do we take, now at this point, do we take the pads off yet? Like, ooh, we said Fred. No, because
leave it on until you can.
Because he could very well go back into cardiac arrest, right? And it's been a while now. It's been several years. This call, if I remember correctly, the medic crew ran on him, and the gentleman, they got him back 3 times in the back of the medic that shocked him. He come back, and he kept going back into cardiac arrest, and he did it several more times in the cath lab before they could get everything stabilized. So yes, if you take these pads off, they're basically one-time use for the most part. So once you stick them on, they need to just stay on until you're absolutely sure you're done with them. And most times, I would just say leave them on until the paramedics show up. Okay? Yes, sir.
Use of an AED with a person that has a pacemaker?
Yeah, absolutely, right? So we want to use that because sometimes we get pacemakers and those suckers have batteries in them. And those batteries do die and they need to be replaced every 8 to 10 years. And maybe more now with new battery technology, but they do need to be replaced and checked sometimes, so maybe that pacemaker is no longer functioning, okay? Or maybe it's just something else going on that the pacemaker can't handle. So absolutely, yes, we would use it.
So it's not contraindicated?
No, sir.
No. So chances are you'll need to do, bystanders will have to do CPR, but once we get there, we can actually pace a patient with our pads.
Analyzing heart rhythm.
If their heart's strong enough.
Stay clear of patient.
So we're still doing CPR on this one, we're done.
Analyzing heart rhythm. No shock advised.
Shock advised again.
If needed, begin
Check for a
CPR.
pulse. He's not breathing. I'm going to continue my CPR. So that was 2 times. So we're roughly at 6 minutes. Hopefully those paramedics will show up pretty soon. Yes.
Person with a defibrillator, just call 911.
If they have a pacemaker defibrillator
They have a defibrillator.
built in?
Yep.
Yeah. If they do, again, it's usually those are mixed in with the pacemakers. Not usually, but they are sometimes. Again, if they have one, still call it. Especially if you go on calls where like that thing is firing off. Like they're awake, sitting up in a chair, and they're like, ah, I feel that. And it looks horrible, because they're getting little baby shocks when they need it. And if that's happening, that's because the defibrillator is picking up some abnormal rhythm that's causing it to work. And if that's happening, that means you need to be calling 911 or get into a hospital very quickly. So yes, that can happen. Yes, sir.
You said something about a shockable routine, and I noticed that the unit advised not to continue CPR. If it doesn't detect a heartbeat, why wouldn't it suggest another shot?
Because there are certain heart rhythms, and we're getting into like some physiology, some anatomy stuff, but there are certain heart rhythms that can't be shocked. So we go through class in cardiac school, and we have a monitor, and it shows us what the rhythm there. We have to actually learn to read that and know what it is. But there are only certain rhythms, and to keep it real simple, right? You can see the beep beep. You see that on TV shows and hospitals if you've ever been. And then you have it goes into like V-fib is what they call it. V-fib is one of those shockable rhythms, and what that's doing is the heart is just quivering. It's not beat. It's not pumping efficiently. Like usually, the heart goes boom 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 boom. The heart's not doing that anymore. Now it's just doing this. It needs something to tell it, to give it some organization, right? So what we do is with the AED is we shock that rhythm, and people think that we're like jump starting the car, but it's not. It's more like, you ever had that blue screen on your computer? And you're like,
stop CPR.
It's going to tell you to stop, I promise you. So with the blue screen on the computer, what do? You reboot it. The AED is more like rebooting the heart than it is jump starting the heart, okay? And then there are some rhythms, so you go from a good rhythm to V-fib to the flat line. Now the flat line, that means there's no more electrical activity in the heart and you can't do anything for that electrically. All you can do is do CPR.
We only shock about less than 25% of the time,
yeah.
Patient. So the other 75%, they're in a different type of rhythm, and CPR can hopefully help.
Medications.
But you're saying that if your heart flatlines, there's no hope for recovery?
No, there's just no more electrical activity in your heart.
Do CPR.
So you do CPR, and that's when some of our medications that we push, that's when they come into effect. They kind of get some of that spark, if you will, back. And once we have a spark, now we can organize the spark with the AED. We get it organized, we get it where we want it to be.
So one thing in movies and TVs, you watch TV and it's just a line and it's going.
And they shock it.
What do? That's not what we do. That's not a shockable rhythm.
They do that in TVs because we all recognize that as being dead, so they shock it.
I hope that makes sense. So like what he's talking about, when the heart is pretty much in fibrillation and someone installs that, a doctor puts a defibrillator in their heart's doing this and quivering, it just reorganizes to get it back to do this again. So that's why you asked, would you go to the hospital? Well, it's the heart. I mean, that's
that defibrillator shouldn't be working.
This is the MVP of it.
Yeah.
So when this went off, something went real bad. You need to go in. So I hope that helps. So you hear boo, and it's on TV. Shock, boom. That's not real life. Shock it.
Since these are everywhere now, is there ever a thing where this would cause more damage?
No, ma'am.
No. Matter of fact, you get more saves with this than you do CPR alone. If you were alone in this building, if it was me and you in this hall here and I went out, it would behoove you and be better for me for you to go out there in that hallway, grab the AED first, put it on, and use it first before even attempting to do compressions or even calling 911 if at all possible. So to go back to it's going to tell you, yes ma'am.
Is that because of size? Because she's tiny and you're...
No, it's all just physiology and what's going on with the heart. It's just...
If it was a little baby, it would be opposite. A little baby, most likely, chances of that, unless they have a known birth defect, basically, chances are they're choking. And adult, chances are there's something wrong with their heart also.
We have worn out parts as adults. So we need something to intervene with that. Kids, sometimes, if you want to think of it like that, it's like their brain is still forming and they forget to breathe. Keep it simple. Their brain, those neurons are still trying to make connections, having to tell them to breathe. We've gone through that. We're good.
Would Would you use this on children or a baby?
So you can only use an AED on a child or baby if the pads in the machine indicate that they can be used on a child or baby. So when you open up the pads, they'll be, there more times than not, they'll say like infant pads, or what they'll really say is child pads. Infant pads are starting to hit the market and you're starting to see them, but commercially, they're probably not widely available. Last time I was here, again, I refer to that, the pads that y'all had here were for adults.
So you can put that on a child then?
Now, this is an American Heart Association class, okay? So I'm teaching to their standard, but if this is a child, okay? This pad has to go here, and this pad has to go here, and this is a child, right? Here's the problem with adult pads on a child. Pretend my hands are the size of the pads and this kid was small. If they're touching like this because they're too big, that causes a direct short for you electricians out there, right? We can't have that because that will do damage, all right? What can you do? You could take this pad that's supposed to go here, throw on his back, and you can do that, okay? Most pads will indicate that though. Every brand is a little bit different. Like in Denton, the pads that we carry, they say on the package, for adults or children. You just got to make sure that the pads aren't touching if this is in fact a child.
Children, like Chief said, I just want y'all to be aware that children, extremely resilient. It's usually a breathing issue. It's something that has happened. They're choked, they've drowned. Adults have drank beer and ate fried food, and I mean, there's a lot more hard issues with the adults.
Well, the only reason I ask that children, a lot of us probably have grandchildren.
Absolutely. Sure. Absolutely. So with that, just to kind of keep it a little bit simplified for you, is I just want you to know, drowning, choking, that's what causes a kid to really have a CPR situation. It's not really a heart issue with it.
And unfortunately, about 18 years ago, we did have a child pass away at Robson Ranch, and it was a choking issue. It started off as choking, and then turned into a CPR.
Do you guys ever do like first aid courses? What was the question?
Yes, the city of Denton does do first aid courses. We've sort of let Parks and Rec department do the first aid stuff now. And we're focusing on cardiacs. But yeah, we can do first aid courses.
We got a class, which that class is just kind of, it's more of a, we've talked and we talk about things and then we bring some materials that we practice something with. Very little, just more of a discussion. If anything, it's about an hour and a half.
Could you show me on either yourself or the dummy? I have a hard time finding my calls. I can't find it.
Okay.
So where are you placing?
So 2 fingers right on the jawline, the V of the neck right here. Okay? Right under your jawline and the V of the neck right there. Just kind of place them, just kind of sit there and hold it. Still can't? I know you have one.
I know.
You better have one in this class because somebody's going to want you to We'll check. All right. So guys, one last thing before we are done. We went over the AEDs and we went over that. Let's see that we're see that we're getting over our time limit here. You guys will see that y'all have.
Even if I had to use the one that I gave.
Oh, okay. We have these that we passed out. Okay. You also have a couple of books on you. Please take those books. Those books are for you to pass out. Yeah, the books are for you to take home and read for you. Some good reading. You can pass it out to friends. So what this is a mouth barrier. I'll open mine so you don't have to open yours. My first modeling job. No, these are different ones. These are the masks. Okay. So the way these work are, you just gotta read it to go over the mouth, and then it's like a surgical mask. Kind of has these ear hole deals. And you put it around your patient, put it around his ears. This goes in the mouth right there. And if we're doing our compressions, and we're going to do 2 breaths for them, lift the chin, pinch the nose, then we can breathe. So we have a mouth barrier now, okay? One-way valve, it keeps all the nasty stuff out, the plastic does, and then it has a medical grade filter in there to help you keep the heebie-jeebies away from you, okay? You can carry that in your purses or your keychains and things like that, and that's what that is. Okay? This goes over.
For your closest relative.
For your closest of close.
If you're in one of the buildings in Robson Ranch and you get one of the AEDs, there's a little red or black bag that's connected to the AED. There's a lot of good little things in there, including the barrier. There's some scissors to cut their shirt on. There's a pair of gloves. Those are sort of clothes, I think. You don't really have time.
Sorry, I didn't understand, but you're saying you put that over your mouth and then you're fixing to know it's how they in the air?
The patient.
The patient.
Right.
So like this, and so then you're blowing into this valve.
Oh, there's a valve.
Right there.
It's a one-way valve.
Yeah.
Okay.
You just blow it, and you're just blowing into
All right, I
this.
didn't do that.
Okay? No problem. Guys, I think that is the gist of it. I'm definitely here to answer some questions if y'all want. If anybody wants to do a little bit extra practice, we can do that.
I would recommend coming up and running through the AED because things can get a little, I've heard before, it intimidates me. So I just want y'all to be familiar with turning the machine on and let it do its thing. It's like this is, y'all are so fortunate here in this community to have these at so many places. So I just want to make sure that y'all get a little hands-on on that. Turn it on, put the pads on, see what it looks like.
Pickleball gets pretty serious.
Oh, man.
And your books do have information about first aid too.
No, there's a little lady for the pickleball. I think they call her the ankle breaker. Hey, I got two left.
Thank you all for being here. Thank you.
Let's get this on. You definitely start early.
Yes. Sorry. No.